Hello, my name is Austin Sim, and I'm currently a PGY4 Chief Resident at Moffitt Cancer Center. Thank you to the ROECSG organizers for allowing us to present our work in progress, integrating leadership competencies in clinical didactic curricula, the mock tumor board. These are my disclosures. In our traditional didactic model, we typically meet 3 times a week for each subsite topic. Generally, we start with a resident-led didactic session, then a journal club reviewing new and/or seminal articles. Finally, we finish with cases to apply and synthesize all of this information. However, we have lots of room to optimize this model. In addition to clinical knowledge, leadership competencies are both important and undervalued. Because of limited time and didactic schedules, many residents have few formal opportunities to learn these competencies despite their practical necessity during and after training. One specific area of need we identified is in multidisciplinary tumor boards, where practical training in conflict management and influence can help us optimize advocacy for our patients in independent practice. In our two birds, one stone approach, we created an interactive simulated tumor board to apply both conflict management techniques and synthesize clinical data. We created 2 different sessions during our GI didactic block with representative faculty from radiology, surgical oncology, and medical oncology. One such case was about the use of stereotactic body radiation therapy for pancreatic cancer, and the second case mostly dealt with cases of organ preservation and non-operative management for certain rectal cancers. Faculty were coached to be deliberately confrontational and challenge trainees. Trainees also got relevant articles to prepare, but did not receive the cases in advance. This resulted in a more real-world application exercise rather than a traditional journal club presentation. These were the articles that were received for the first case. Specifically, we had to defend our recommendations for systemic therapy, radiation therapy, and a follow-up regimen for both a locally advanced case and a borderline resectable case. The first patient was eventually treated with adaptive MR-guided SBRT, as shown in the images there. The second session went through a variety of rectal cancer cases, starting with non-operative management for a low T2N0 rectal cancer. For subsequent cases, we were given other articles and abstracts to defend our positions in the clinical scenarios listed below. In addition to serving as a better way to apply clinical data, this approach also provided additional practical application of topics we explore in our unique longitudinal leadership class for radiation oncology residents at Moffitt. For this pilot year, we did not conduct formal session evaluations, but for subsequent years, we will aim to perform a multifaceted evaluation with surveys, debriefs, and structured interviews to help improve these sessions. We envision eventually restructuring sessions for all other disease sites in future years as well. I would like to thank my co-authors, including our residency program leadership, our co-residents, and of course, our faculty participants for these sessions across the other disciplines. We welcome additional questions and discussion during the live meeting. Thank you.